Good morning, everyone. I'm Dr. Anud Saati from Military Hospital in Saudi Arabia. I'll be talking about a very fascinating topic that has been described early in 2005. How do we win the battle of a small pupil and floppy iris syndrome? In 2005, Dr. Campbell and Dr. Chang gave us the awareness about the possibility of an iris that does not behave properly during surgery, and this increases the rates of complications and sequelae and side effects. I'm sure many other surgeons have been seeing this, but these two took the trophy for alarming us about it. The iris, intraoperative floppy iris syndrome, how bad can it go? Once the surgeon loses visualization from a non-behaving iris, sequela starts like a chain, and one after the other complications happen. But if you know it, you know that you can stop it and prevent it or reverse it. The key here is to have proper history taking. And what should you be asking about? The risk factors. Risk factors for intraoperative floppy iris syndrome, and excuse me, I would like to name it as floppy iris syndrome for short, is attributed mainly to the use of one drug that is an alpha blocker used for benign prostatic hyperplasia. Now, the iris structure is unique for its vascular, muscular, neurological structure that is at consistent function in fractions of milliseconds, dilating and constricting with no stop. This structure has alpha receptors that are the same as the ones in the bladder, and urologists prescribe alpha blockers to reduce the urine retention. And unfortunately, the iris also responds and it stops dilating. The number one drug that has the potential or develop an IFIS is tamsulosin. In generic name is either Omnic Ocas or Flomax, and even a single dose of this can cause IFIS. The other categories of drugs like Cardora or alfuzacine have less potency on IFIS. However, not only patients on alpha blockers develop this condition, and I'm sure plenty of us have seen cases that have a floppy iris during surgery and they have never been exposed to alpha blockers. These two papers have nicely described that the relationship is not only with the drugs, it has very strong relationship with hypertension, which is a very common pathology in our community. It's about 75% related to it. Male gender has like 9 times are more likely to develop it. And the alpha blockers depends on the category of drug they're using. It has no association, surprisingly, with diabetes, though diabetics have poor dilation response, and it's not necessarily bilateral disease. One more thing, an over-the-counter drug usually used, that is Palmetto. It's also sold in the pharmacies as an organic drug for BPH, and this paper has shown that it has a strong association, but not statistically significant. What are the signs of iris floppy syndrome? The first sign is an iris flutter. That is, an iris makes waves as you inject fluid into the AC. And this is not what you really see with a good toned iris. The second sign is the iris has tendency to go out from the wounds because of the pressure gradient. And that's what you don't see with a normal behaving iris. And the third sign is the constant loss of dilation or pupil constriction of more than 2 millimeters. And this photo shows how the pupil in the middle of the surgery has become small during phacoemulsification. Now it's graded. If it is only one sign, that is the iris flutter, it's stage 1. If it is 1 and 2 or 1 and 3, it's moderate. And if it's all 3 of them, it is severe. Scenarios in surgery. So you either anticipated it and you were good, you took good history and you know that you're going to have an IFIS syndrome, or you are completely surprised. I have lost my screen there. Okay, anyway. So if you anticipated this as a preoperative measure, well, you need to do first thing for yourself is protect yourself and take a good patient consent. You consent the patient for the rate of the complications. Do not promise them what you can't do. Tell them if they are asking for multifocals, for premium IOLs, it is a possibility that you might not be able to do it because their eye does not behave normal. And do not stop alpha blockers, as this is not going to help because even a single dose can have a permanent effect on the iris. Patients may benefit from atropine 1% TID for 2 days before, and this was described by Dr. Samuel Maskets previously. Intraoperative, and you have to go in with all your weapons ready. You have to have a proper wound construction. I generally go a little bit more corneal. I stay away from the limbus, and I use a slightly longer tunnel to make sure that my iris will not have access to the wound. Intracameral phenylephrine. In every single case of my surgeries, I use intracam phenylephrine if there is no contraindication. I use it as a cocktail, and I like to name it a cocktail because I add xylocaine, 1% preservative-free, along with BSS and phenylephrine 1 in 1,000, or sometimes adrenaline. Omidria is another good drug that is available in the market, and it's a ready-made solution to put as an intracameral drug. Iris hooks, iris rings, iris retractors, whatever tool you have is all available and can all work well. And I just generally would like to comment that these tools are very helpful, but you need to know how to use it. I do not prefer them in shallow anterior chambers or with beginners because they can cause more damage than help. And my preferred is the iris hooks. During surgery, you have to have a very controlled capsulorhexis in case you needed to put your lens in the sulcus. And I have to avoid the pressure gradient, use a dispersive viscoelastic, and make sure that the viscoelastic does not stay behind the iris and pushes it back. Now, I have a couple of videos, but I'm going to show you when it's a surprise, because this is the one I think you need to learn from. So here's the one patient that I have been operating on, and you could see that I am injecting my dye. I think I was trying to teach a resident here, but when I found that the pupil does not dilate, I took over. I had a very smooth capsulorhexis. It went fine, yet the pupil is semi-dilated. However, if the rhexis goes well, hopefully everything else should go well. Now here, as I'm injecting my hydrodissection, you will see how I increase the pressure and pop, the iris goes out. Now I try gently to push it back. It's a little bit fast forwarded, so you see that I'm aggressive, but the iris went back nicely. I try again to complete my hydrodissection, and the iris comes out again. So now, at this point, you can either panic or go ahead. I decided to go ahead. I forgot about the iris that is out, try to do a little more hydrodissection. Even if this iris is out, it's not gonna die for a few seconds. Just minimize the manipulation. Try to gently push it back. And here I'm putting OVD, but it doesn't want to go back. And it will only go back when I release it from the paracentesis and gently try to reduce the intraocular pressure. I put a little pressure on the wound, evacuate what is an excess OVD inside the AC, and here the iris slightly goes back in. Now I want to continue my phaco. I can either go and put an iris hook now, or be trying to reduce time fast. I have a long list. So here I use my spatula to protect the iris and go in with my phaco probe to facilitate the phaco and continue. Now, as I'm going in, notice that I go in without irrigation. And this is a very important key point. If you increase irrigation, you are increasing pressure and the iris will flutter back again. I try to minimize my exit re-entry during phaco, and my second instrument is actually my masterpiece here as I'm working. It does most of the manipulation because the wound there is very small and the lens material can rock and roll and move around. Now, let's fast forward this here. Now, cracking goes well. You can see the iris is a little bit stretched under my phaco tube. phaco-tip, but it is not engaged in the phaco-tip. As I go forward, phaco goes well. And now when I want to do my cortex removal, now at few times you can capture the iris, but don't let this bother you. Your second instrument should be able to push it back away, and you can continue aspirating your cortex. Now, that's why I insisted on hydration, because if you don't have good hydration, everything else is going to be bad. And even if you captured the iris once or twice, just be careful. Don't have to go fast. Just have your foot ready for the reflex pedal. Now I want to go in again and put my lens. But before putting the lens, I had to enlarge my wound slightly because my lens goes only in 2.4 millimeter, and this was a 2.2 wound. So what to do? I generally put a few drops of viscoelastic in the AC. I do not over-infiltrate. I'm using a dispersive OVD, and here I put it just on the wound to make sure that the iris will not pop out. Use your spatula through the second port to protect the iris, as I want to enlarge my wound slightly. And then everything should go smooth. Inject your lens smoothly, and there should be no problem after this. If I have an IFUS, I put a suture. And when I want to put suture, I put a few drops of viscoelastic exactly on top of the wound to make sure that I will not engage the iris as I'm taking my bites. And that's it. You can put an air bubble at the end or not, depends on how much power you use during surgery. Now, going back to the other two videos, I think this would be, yeah. So I have anticipated this. I know that this patient is not responding, and I will need to give this patient my cocktail. He's also not responding. I used my OVDs. He's also not responding. So what to do next? You can either panic or go for the second step. And my second step at this point would be using Coughlin hooks. Now, the Coughlin hooks are a very, very useful tool. You can crisscross them, or you can push each one to the other side. I prefer to push each one of them to the other side and avoid crossing because they can get tangled and cause more complications. And for every side, I make it like 180 degrees apart. It should stay for 30 seconds. I do count until 30, my resident and I, until we get that fully dilated. And here everything goes on smooth, and it remained dilated. So this is like a moderate case that behaved well during surgery. Here's another case that did not behave well during surgery, and it was quite challenging because it's intumescent and it is an IFUS syndrome as well. And in this patient where things did not go well, I had to take my decision and use early on. Coughlin hooks didn't work. You can see here after the Coughlin hooks, I put usually dispersive OVD after pushing it and trying to see how well it will be. Unfortunately, it became smaller than I expected. I put a little more of Vision Blue just to dye because this is intumescent and I want to make sure that my visualization is perfect. So I go ahead and decide to use my iris hooks. The most important one is the one subincisional. You don't want to make a skirt of two iris hooks on the right and left side and have the iris hitting your phaco probe every time you go in and out. So I prefer to use them and this gives me very wide pupil. In short, IFUS is strongly related to hypertension and alpha blockers. Practice the detailed history taking to be prepared for it. The key to avoid complications is avoid pressure gradient in the eye. Proper tunneled wound, corneal, away from the iris plane is the best. Intracam phenylephrine helps significantly. Dispersive OVDs are always used in these cases, and better to learn how to do pupilloplasty if in case you had a terrible complication. Thank you very much.